Hello, my name is John Moyer, and I want to welcome you to the NIH Office of Disease Prevention's Mind the Gap webinar series. This series explores research design, measurement, intervention, data analysis, and other methods of interest to prevention science. Our goal is to engage the prevention research community in thought-provoking discussions to promote the use of the best available methods and to support the development of better methods. Before we begin, I have some housekeeping items. You can submit questions during the webinar via the chat pod. You'll need to open the pod by hovering your cursor at the bottom of the Zoom window and then clicking on the chat icon. Please direct your questions to hosts and panelists. We will open the floor to questions that have been submitted via the Zoom chat pod at the conclusion of today's talk. The slides and video recording will be posted on our website, prevention.nih.gov/mindthegap, in approximately 2 weeks. Lastly, we would appreciate your feedback about today's webinar. Upon closing, you will be asked to complete an evaluation. We would appreciate your feedback as it will help us improve this webinar series. At this time, I'd like to introduce Dr. David M. Murray, Associate Director for Prevention and Director of the Office of Disease Prevention.
Thank you, John. Today's speaker is Dr. Anthony Biglan. Dr. Biglan is a senior scientist at the Oregon Research Institute and founder and president of Values to Action, a nonprofit organization that helps communities come together around a shared vision and create action circles to implement evidence-based solutions to their most pressing problems. Dr. Biglan has conducted research on the development and prevention of child and adolescent problem behavior for the past 40 years. His book, The Nurture Effect: How the Science of Human Behavior Can Improve Our Lives and Our World, summarizes the accumulated knowledge about what humans need to thrive. His more recent book, Rebooting Capitalism: How We Can Forge a Society That Works for Everyone, describes the recent evolution of a rapacious form of capitalism and presents a framework for evolving more nurturing communities. Dr. Biglan's recent paper, Prevention Science and Health Equity: A Comprehensive Framework for Preventing Health Inequities and Disparities Associated with Race, Ethnicity, and Social Class, summarizes the extent to which public policy has contributed to harmful social and material conditions for families, conditions accounting for a large amount of the variance in disparities in premature death. The paper argues that our progress in reducing disparities will be limited if we do not develop comprehensive community interventions that address all of the risk factors for health disparities. He argues that doing so will require greater use of interrupted time series designs. It's my pleasure to welcome Dr. Biglan.
Thank you, David. Well, let me start by saying that as I worked on this talk, I decided that the title really should be somewhat different. So I would say that this talk is about a research and public health agenda to improve population health and reduce disparities. And the reason that for that change is that I think that we have a situation in this country where the health disparities are due to a whole host of risk factors that we really haven't put as much attention to. But ultimately, I think if we're going to produce the kind of changes that we all aspire to, that we're going to need a social movement that uses all of the methodological tools in our quiver, but also engages far more people in trying to improve well-being, and primarily at the community level. So to me, the ultimate goal of public health is to reduce the incidence and prevalence of psychological, behavioral, and physical disorders in order to prevent disability and premature death. I came to the public health approach because I, like David Murray, was doing research on smoking prevention, and that's basically the story in smoking prevention, and or any aspect of prevention, is reduce the incidence of starting and the prevalence of people smoking. And so I found that the framework that I apply to virtually every aspect of society. So I would argue that we are making limited progress on that goal. On life expectancy, we rank 28th out of 36 countries that are members of the Organization of Economic Cooperation and Development. Suicide rates have increased in recent years. Drug overdose rates have reached historic highs. Binge drinking has increased among those over 50. And by 2018, the prevalence of obesity in the US population of adults over 20 was 42.4%, and the prevalence of severe obesity nearly doubled from 4.7 to 9.2%. And for all of these problems, you can point to preventive interventions that have been shown to have some benefit, but we are not changing the prevalence of these problems in the population. And so more is needed. And so that's where we're going to go. So health disparities are also rampant in this country. As of 2015, Black people under 65 had higher death rates than whites for all-cause mortality. Rate of all-cause mortality among Native Americans is 30% higher than the rate for all races. Mortality rates for non-Hispanic whites in the US stopped declining around 2000, and then they increased. Well, they continued to decline in 6 other countries. And lastly, mortality rates also differ by socioeconomic status, with disparities for low SES on the rise in recent years. There's a slide at the end of this talk that has references for all of these statements. So this is a figure from the paper that David described that we published recently in Prevention Science. And in it, we argued that in order to affect disability and premature death, we need to address risk factors such as tobacco use down to high cholesterol, kidney dysfunction, and so on. These are the risk factors that, to a great extent, we have been focusing on, and we're making progress in affecting many of these thanks to the research that has been done. But then come back to the fact that our population changes we're not seeing. And we argued that this is due to a large extent to the social determinants of health disparities, which we are not doing as much to affect as we are trying to affect these risk factors. And so the argument is that if you simply try to keep dealing with these risk factors in the context of social determinants such as poverty, discrimination, harmful marketing, and so on, we're going to have a limited effect on population well-being. But in addition to that, you need to understand the role that public policy has played in increasing poverty, increasing child poverty, for example, over the last 40 years, or the degree to which public policy has increased discrimination, or the degree to which harmful marketing of tobacco, alcohol, unhealthful food, pharmaceuticals is killing people. And we are not regulating that because public policy has been in favor of not regulating these things. So anyway, that's a brief summary of that, our thinking about that. And as I looked at this, I kept thinking about, well, how do I describe these risk factors that account for all of these problems? And so I asked Chat OpenAI, my first foray into AI, I said, what is a word for a risk factor that affects numerous outcomes? And it replied, a word that describes a risk factor that affects numerous outcomes is omnifactor. The term omnifactor can be used to describe a risk element or variable that has a broad impact and influences multiple outcomes or situations. It suggests that the risk factor is pervasive and can have wide-ranging effects across various domains. And I submit that public policy is an omnifactor, and that the problem and all of these social determinants are omnifactors. And I never heard the term omnifactor. When I asked for another term, it suggested multifaceted risks. But in any case, the point is that we need to be focusing on these risk factors that affect so many different problems, because it's when we do that, we can have an effect on all these things. I have been looking for an epidemiologist who could help to figure this out. We have an analysis of the population attributable risk of a single risk factor for a problem. But what we need here is an analysis of the impact of these factors. And so let me elaborate on that with the example of child abuse and neglect. Values to Action recently helped a number of a network of organizations trying to end child abuse and neglect. And I had not appreciated the degree to which child abuse and neglect is a risk factor for every one of these health and behavioral problems and psychological problems, including school shootings. And so when you look at the impact of this factor on all of these problems, you realize that we have got to focus on reducing child abuse and neglect because it's likely to have an impact on reducing all of these different problems. And so that child abuse and neglect is another omnifactor, and we've got to address those. I also would ask you to consider the risk of problem behaviors and the interrelationship among problem behaviors. This is from a study of 8th graders in a representative sample in Oregon that we did several years ago, where we looked at the degree to which a kid who indicated that we're engaged in substance use, what was the relative risk of antisocial behavior? It was 5.5. It was 8.5 for risky sexual behavior, 3.6 for depression, and so on. Every one of these relationships is quite large and significant. And so my point in saying this is that given these interrelationships, it seems to me that it's unlikely we can excise one of these problems if we don't alter the other problems and the conditions that contribute to multiple problems. And so we need to move toward a research that is focused on omnifactors and is focused on comprehensive interventions that affect multiple problems. So the Office of Disease Prevention is one of my favorite places at NIH. I think you've done some excellent work on this, and I've been very impressed by it. I'm particularly impressed that you invited me to give a talk. So this is a summary of a paper by Vargas et al. That came out of Office of Disease Prevention. Their analysis concluded that the leading risk factors and causes of death and disability were underrepresented in the NIH prevention research portfolio relative to their burden, because so much is already known about these risk factors and causes, and because randomized interventions play such a vital role in the development of clinical and public health guidelines. It appears that greater attention should be given to develop and test interventions that address these risk factors and causes, addressing multiple risk factors or causes when possible. And I don't know if you can see my cat, but this is the way to do science, I will tell you. But I've emphasized addressing multiple risk factors or causes when possible. And of course, the difficulty there is that it is harder to do that. But I would argue that it is essential that we figure out how to do that. And so on that basis, I think we need research and public health agenda that gives greater attention to the most important risk factors, the social determinants, the policies that affect social determinants. The comprehensive community interventions are needed because it's certainly useful to do a study of an intervention in a community focused on one outcome, but ultimately, because of the interrelationships among these problems, we need to provide comprehensive community interventions. And ultimately, we need a social movement that makes us use of all of the empirical methods that are available to us. So it might seem like it's beyond the charge of NIH to create a social movement. But I submit that the NIH has already done that. And one of the best examples is the tobacco control movement. And I suggest that that provides a model for affecting population health. The tobacco control movement, which was heavily funded by National Institutes of Health, focused on awareness, public education, and advocacy. It focused on policies, the impact of taxation on tobacco use, the impact of smoke-free policies on smoking, restrictions on the marketing and its impact on smoking. And it also focused on access to smoking cessation resources and community interventions. And and leading all of this was the media advocacy. the Surgeon General's reports that came out that documented, first of all, that cigarette smoking caused lung cancer, but then there was just report after report of all of the ways in which smoking harmed people. There were also National Academy of Science, Engineering, and Medicine monographs on tobacco use and institute monographs like NCI put out. But there was also cultivation of news media. This should say news media. I thought I'd corrected that. Because, you know, it was important. Increasingly, the Surgeon General's reports were getting considerable attention when they came out, and it was affecting public opinion. And so what you had was a situation where the increasingly the epidemiological studies, making clear all of the harms of cigarette smoking drove the media advocacy, and the media advocacy increased support for public policies, but it also changed public opinion. And of course, policy and public opinion are reciprocally related. And so this is a model that I think is relevant to what we need to do. We need to have these epidemiological studies and the reports of them much more widely used. We looked, for example, at the degree to which a similar thing has happened with respect to child abuse and neglect, and it hasn't. There are very few federal reports on child abuse and neglect compared to what we did in the tobacco industry. So let me talk a little bit about research on policy. The Chapin Hall at the University of Chicago has done an excellent job of analyzing the role of policy in child abuse and neglect. And this is a slide I stole from them that lists the policies that have contributed to the financial difficulties of families, especially families of color, that are all risk factors for child abuse and neglect. And so these are the kinds of policies that we need to affect. And their report went on to summarize all of this in terms of a family investment model. Families receive sufficient economic and concrete supports. That's the first thing. Families have resources to meet their basic needs. Families can invest in services and opportunities for their children. They have access to housing and childcare and educational opportunities. All of these factors are relevant to lowering the risk for child welfare and involvement. And so this is an area that is made considerable progress, but now we need to get better at getting these policies more widely adopted because they have empirical evidence that they reduce the risk of child abuse and neglect. And so we come to natural experiments. This is one of the things that has been exceedingly important in the development of our understanding of the effects of economic policy. And the Chapin Hall analysis, if you contact Claire Anderson at Chapin Hall, you can get a copy of their slide deck, which they are disseminating widely. It presents a wealth of evidence from natural experiments showing the benefits of economic support. And I would point out that David Card got the Nobel Prize in economics for his research analyzing variability among states that differ on their minimum wage. So there's some, you can make an argument that this is good science. And these are examples of studies of natural experiments that benefit that show the benefit the earned income tax credit for reducing child maltreatment. So then there are community interventions. And NIH has created COMPASS, community partnerships to advance science for social, for society, a common fund proposal. And they are attempting to change the social, physical, economic, and political environments that shape or constrain health behaviors and outcomes. And when I became familiar with this, I went, this is exactly what I'm calling for. The notion is to span the institutes, and because they span the institutes, they can thereby attend to omnifactors. The institutes are largely focused on the problems, and so it's natural for for example, the National Cancer Institute, to focus on anything that has to do with cancer. But those omnifactors can sort of be obscured when you start with a particular disease and say we're going to work on that disease. But if we worked on things like poverty or child abuse and neglect, you have the potential to affect numerous problems. And so and I would argue that the way to do that is to work at the community level. So this is addressing the social determinants of health, and it's organizing communities, and that's where we need to be. So now I want to talk about the value of multiple baseline designs in this work. And I will say, and David and I were talking before this started, that Alex Wagner and Dennis Airy and I published a paper in 2000 about the value of multiple baseline designs for work in communities. And David and his colleagues subsequently published a paper suggesting that these interventions, these methods were not particularly useful in public health. And when I read that, I went, oh, I'm going to write something about this. And to David's credit, when I sent him a paper that discussed that, he invited me to this. So hooray for David. So let me walk through this for you. Randomized trials, I would argue, are premature when we lack nomothetic principles. A nomothetic principle is one that applies to all cases in a particular category. The term is often used in contrast to idiographic principles, which apply to individual cases. And I want to argue that it is research that began with individuals, individual children, individual families, that led to principles that were replicated across multiple individuals to the point that we had nomothetic principles. And I want to argue that the success of randomized trials in family and school research resulted from the elucidation of nomothetic principles that emerged from numerous interrupted time series designs, which consistently showed the impact of reinforcement on behavior. You should keep in mind that the first study showing the impact of reinforcement on human behavior only occurred in the 1960s. So this is all new stuff. And so let me walk this through with respect to families and schools, where we've made enormous progress. And so first, this is a study. Charlie, you need to get off my lap. Thank you. The effects of reducing attention on aggressive behavior. This is just one example. I could give you many more. So here is a study where the percent of intervals scored for aggressive behavior was the dependent variable. And so they had a baseline with one child who was actually getting a fair amount of attention when that child was aggressive. And then the experimental condition, they withdrew that reinforcement and were careful not to reinforce aggressive behavior. And as you can see, it went down. This is an ABA design. Then they went back to baseline and it went up. And then they went back to the experimental condition where they were not reinforcing aggressive behavior and it went down. So that was just one example. There are many more. And as they accumulated, the nomothetic principle emerged. Parental attention to problem behavior and reinforces it. Parental attention to pro-social behavior reinforces pro-social behavior. And I have members of my family who have benefited from that knowledge. So here's a table from Leslie et al. Paper published in 2016. The paper was focused on the value of family interventions and the possibility of reaching parents through physicians with these programs. So this is just a summary of these programs. I put in red their impact on child abuse and neglect variables because I use this in some of the work we did with child abuse and neglect. And this is the second thing, 16 papers describing family interventions that have been shown in multiple randomized trials to have benefits. And I submit that that is thanks to the accumulation of the nomothetic analysis. And so I'm just going to move on from that. So now let's talk about schools. There was a teacher in the 1960s at the University of Kansas. Her husband was at the University of Kansas, and she was come to Lawrence with her husband, and she got the third grade that she was going to teach. And there were 3 third grade classrooms, and the teachers who were there the previous year had organized which kids would go into which classroom. So guess which classroom she got. And so by Thanksgiving, she was ready to quit. And so her husband took her to talk to Montrose Wolf at the University of Kansas, and they figured out that when the kids were best behaved when they were doing some kind of interesting task together. So they did both a multiple baseline and ABA design here. So what they did was they tracked the rate of talking out and the rate of out of seat behavior. You can imagine being a teacher having these rates of these behaviors, you'd be ready to quit too. What they did then was they set up a system where if the kids were on task for a fixed period of time, they would get a reward. And what they found was that there was a significant decline in this kind of disruptive behavior. And then they reversed that and stopped doing the rewards, and they got high levels of disruptive behavior. And then it declined when they reinforced it. And then they replicated that in the reading period where they had baseline for all of this period. And then when they introduced reinforcement, they had significant benefits. Now, this behavior analytics study published in the Journal of Applied Behavior Analysis was replicated in numerous studies over about a 40-year period. But behavior analysts were always skittish about doing randomized trials, and so they never really did one. And along came Shep Kellum, a psychiatrist at Johns Hopkins University, and he took the good behavior game and he did a randomized trial and with kids in first and second grade. And what they found was that the program produced all of these benefits. And I'm just going to go to the 5. These are kids who got it just in first and second grade: reinforcement of pro-social behavior, cooperation. What they found was that by middle school, there was less tobacco use, less alcohol use, fewer conduct disorders. By the time these kids were young adults, there was less depression, less crime and violence. They were more likely to graduate high school and attend university. And these benefits have been shown in additional studies since then. And so once again, a nomothetic principle arises, and when it is applied, you can do a randomized trial. But the potential of now I want to talk about the potential of multiple baseline designs to identify large changes that can affect populations, even in the absence of RCTs. In the late 1990s, we got a grant from the National Cancer Institute to do a randomized trial of a community intervention to reduce tobacco use. And those were the good old days. There was a $500,000 limit. You know what $500,000 was in 1995 versus now? I reminisce. So one of the 4 components of our community intervention was to reduce youth access to tobacco. We talked to the law enforcement, and they said, there's no way I'm going to cite somebody for selling to kids. The judge would just throw us out of court. So we tried to figure out what could be done. And one of our administrative assistants said, you're always talking about reinforcement. Why don't you reinforce them for not selling tobacco? So we did. We had kids go in and attempt to buy, and if they were, the clerk were willing to sell, we made a note of it, and that was our baseline. And so we did this initially across 2 communities and a multiple baselines design. So this is one multiple baseline design. That's a second multiple baseline design. And what we found was that when we went in and rewarded the clerk, we just gave them a $5 gift certificate, and we initially got some publicity for them. This clerk caught in the act of obeying the Oregon law. And we had a significant decline in the rates of sales of cigarettes. And in fact, these data points were long after we had stopped doing the reinforcement. And then we replicated that in a second community and got similar results. And then we did it in 2 more communities. And then we did it in four additional communities, each time with a pair and multiple baseline design. And I think this speaks to something, David, that we were just talking about, that it's replication that can make up for the difficulties in the statistical analyses of data points like this. So this is what we got across the baseline and the intervention across those 8 communities. And I suggest that most people would say, gee, that was making a difference. And in fact, Dennis Embry, who was working with the state of Wyoming, saw these data and thought that was the case. And so he helped, there was an amendment called a Sinar Amendment was written that required states to keep track of the degree to which youth had access to tobacco from illegal sales and to reduce those sales. And they could lose some of their funding for drug abuse treatment if they did not do that. So Wyoming was motivated to do that. And so we trained every sector of Wyoming to do that. Here were the rates of sales prior to that. And what we did, and I will tell you that Dennis added some interesting bells and whistles, but we brought the percent of stores willing to sell down to under 10% for all of these years. And in fact, we also had data on smoking rates, and youth smoking rates did go down as a concomitant of this. He then replicated it in Wisconsin with similar results. And so I submit that this is an example of the value of interrupted time series designs, which produce large enough differences to have a public health impact. And so now let me talk about the commit study, a community intervention trial for smoking cessation. This was a randomized trial. It was funded by the National Cancer Institute to test a community intervention to reduce smoking among heavy smokers. There were 11 pairs of communities. The cost of the study was about $100 million. And at 4 years, they found no difference in smoking rates among heavy smokers. There was a small effect on light to moderate smokers. So I submit that they would have done better to do interrupted time series designs on the components of this before they did a randomized trial. And even then, they should have tried the comprehensive set of components on one or two communities until they got a clear effect, and then they could do a randomized trial. So I think a better strategy is to develop each component in a series of communities. For example, take physicians' advice. That was one of the components of commit trial. And there was already empirical evidence that you could significantly reduce people smoking with physician advice. In fact, ORI and Kaiser Permanente did a randomized trial of a physician advice intervention that significantly reduced smoking. But what they found in commit was they had a hell of a time trying to get physicians to do it. And the problem was that they didn't have a system, a set of interventions, a strategy for getting physicians to do this. And that had they done that, let's say you have 3 clinics in a community, you work with one clinic and you do what you can to try and get them to start providing advice. And when you've got a successful strategy, you try it with the next, the next set of physicians, and the third, and then you get better at this. You do it in a 3rd clinic, and pretty soon you've got a strategy that works. A nomothetic principle has developed out of the efforts you've had across a set of clinics, and then you can go on to a 2nd community and test it. So to implement a set of tested components in a series of communities over time. And so when you've got those components, each one working, then you try doing it in 1 community or 2 communities and see if you can replicate those effects across communities. And only then are you ready to do a randomized trial. So many of the areas of research that are vital to progress do not have nomothetic principles. And these are areas where I think interrupted time series designs and multiple baseline designs are needed. So here are some examples. The variables that influence the adoption and implementation of programs and policies. That is an area which is, a huge amount of investment in this. A lot of excitement about it, that we're going to do research to try and figure out what works to get these programs implemented. But there's a frequently cited paper that identified 61 models for implementation. I submit that that's a sign that we don't have nomothetic principles, and that what's needed is to take one kind of organization, let's say schools, and do a study on a strategy to get one school to adopt a specific program, then another one in a second school, and develop those nomothetic principles. The variables that influence communities to improve community member health and well-being, we don't know what those variables are. And until we do, we can't do RCTs. Strategies for reducing police violence. I submit that we have not figured out what we can do to address that. And we need to work in individual communities, testing strategies until we get something, and then see if we can replicate it in other communities. And strategies for reducing conflict in communities. We have a lot of conflict in a lot of communities. I'm not aware of a strategy that's been repeatedly shown to affect reducing conflict in a community. So multiple baseline designs are useful, and I would argue in any situation where you have a time series, the level or slope of which is expected to change as a function of a strategy, policy, or program. Examples would be the sale of sugar-sweetened beverages, sales of alcohol, rates of child abuse or neglect, the unemployment rate, assaults, murder, delinquent acts, contributions to nonprofits working for policy changes, graduation rates. And all of these things, we need to figure out what works and show that in one case, and then a set of cases, and work up to randomized trials or just population efforts. This is all fodder for the social movement that's needed. So lastly, I want to talk about action circles. Action circles, this is values to action. We've been developing action circles and find them very useful. And when I'm talking to people from academic settings, I always compare them to committees. If you've been on a committee in a university, you have a meeting and then you take notes and then you have another meeting and so on. Action circles are designed to get some specific thing done. Our proposition is, if you're troubled by the state of things in your community, if you don't see how you could make a difference, if you are willing to give up you're unwilling to give up your work, your education, your family, and your recreation to try and make a difference, we would argue that action circles give you a way to contribute. And we think that this can be a building block for a social movement, because we're not asking people to give up, to become an activist. We're asking them to spend a short period of time working on a very specific problem, and it's one piece of the puzzle. So the action circles consist of 8 to 12 people who agree to work toward a very specific and delimited goal that can be a building block for further progress. Rather than trying to take on a huge task, they break our problems down into small steps, each of which makes a concrete contribution to addressing a larger problem. Members agree to participate for about 2 months, attending 8 meetings and volunteering 2 to 4 hours a week to the effort. And action circles thus far include increasing the use of evidence-based social emotional learning in schools. We had one that focused on increasing the use of effective reading instruction, which we are now working on getting that to happen in schools around the country. And if you are aware of an elementary school with high levels of reading failure, which is almost every school in America, contact us. We're looking for schools because we can help. We are increasing pro-social values, norms, and behaviors in communities. We're doing a number of things on that area. Then there's the issue of increasing the availability of behaviorally skilled personnel in healthcare. we had an action circle that was working on social emotional learning, and two of the members of that action circle said, one of whom is also a pediatrician and a behavior analyst, said, wait, we need behavior analysts with skills in working with kids with autism to work in hospitals and clinics. That's very few, most hospitals and clinics don't have those skills. And as a result, kids with developmental disabilities do not necessarily get good diagnosis and treatment because they become so distressed that often things don't work. So we created an action circle and we wrote a guide to increasing the availability of those people in hospitals and clinics, and that's been widely disseminated, and we're beginning to work on getting specific clinics to adopt it. Then there's reforming juvenile justice in your community. We had a graduate student who was between her master's and her doctorate program, and she wanted to work on this. So we put together an action circle, and we wrote a guide to reforming juvenile justice in your community. And it doesn't just focus on what you do once somebody is apprehended or adjudicated delinquent. It's most heavily focused on all of the things that can be done to prevent delinquency in the first place. And we have a guide to that, and you can go to our website to get it. Then there's regulating harmful marketing. We put together an action circle that has produced a paper, which is under review, where we're documenting the degree to which marketing of tobacco, alcohol, guns, pharmaceuticals, fossil fuels are all causing considerable death. I can account for easily 1 million deaths per year, excess deaths per year associated with harmful marketing of these products. And so we see that, we now count that as a social determinant of health and a pretty important one. And we're working to try to get the policies that are needed, policies that have been developed in tobacco use, but haven't been nearly as much implemented in with respect to the other products. Then there's reducing greenhouse gas emissions. We've had a number of action circles working on that. And most recently, we've developed a national plan for reducing child abuse and neglect by creating a social movement to do that. And we have a document soon to come out on that. So let me just give you two examples. Suppose you wanted to deal with underage alcohol consumption, excessive and underage alcohol consumption, because there's also a problem of excessive use among adults. So what would you do with an action circle? Well, the first thing you do is you document the extent of the problem. You document it in your community, you document it in epidemiological studies that have been done across the country. So a couple people in the action circle could take that task and do that in 2 months easily. Then you identify evidence-based policies that could be implemented at the community level. You review the evidence on that, and you come up with a set of things that could be done at a community level. Then you get data on the barriers and facilitators of policy adoption. And so you're getting clear on what would make it difficult to get a policy adopted and what would facilitate it, because you're trying to figure out what policies to choose to work on, to advocate and implement. Then you identify influentials and organizations that might be persuaded to support the policy. When we worked in tobacco use in communities, we started with the physicians. They're the easy group and they're high prestige in the community, and they come out and say, you know, we need to do this. And so you organize, you do community organizing, and you get all the sectors of the community to get on board with this, starting with the ones that are most likely to agree. And then you go to the next sector and say, well, these guys said you could do it. What about you? And so you organize the community. Then you develop an advocacy plan. How are you going to advocate for these things? And that's there's a literature on community organizing and advocacy, which, by the way, is the people at the Pennsylvania State University are doing some excellent work, doing randomized trials of strategies for getting policies adopted. If you email me, I can connect you with them. But then the next thing you do is create the next action circle to implement the plan. And it doesn't need to be the 10 to 12 people who are on the first action circle. In fact, it's good if there are additional people or different people that do this, because what we're trying to do is create action circles across all of these different problems. and we see this as the leading edge of a social movement. So then the generic features of work of action circles working to improve community well-being. Compose a cross-section of people who wish to improve well-being in the community. We're now offering stipends. We're about to put out an RFP inviting people to create an action circle in their community, which we will support them in doing. We don't have very much money, and if you would like to donate to Values to Action for this purpose, we will allocate the money to support these action circles. We compose a cross-section of people who wish to improve well-being in the community. Then we identify a risk factor that's an omnifactor affecting a wide range of problems. Family poverty, for example. Identify policies and practices that have proven benefit in affecting that risk factor. Identify influentials and organizations that might support the policy or program and objective and enlist their support, and develop an advocacy plan. And then what do? You create one or more action circles to implement the plan. An action circle that listen to the community about the issues that they're most concerned about, it would be a good starting point for this. And you might find that youth substance use is one, child poverty is another, a variety of things. But in every one of those, we have the evidence. All we need to do is organize action circles to make use of that evidence. And so I would argue that the Compass Initiative has the potential to bring about population change and a reduction in disparities that could drive a social movement. However, this work will require experimental evaluations. Much of the experimentation will require multiple baseline designs that pinpoint generalizable principles that could enable randomized trials. However, the results of multiple baseline designs may often support applications to multiple communities or states, even in the absence of RCTs. I guess the other thing I would say is that if this seems to go beyond the focus and methodology that has gotten us to where we are now, we need a social movement. We need a movement that enables millions of people to become more active in doing these things, in making a difference. And I think that is the way we work our way out of this. Even in states that are unlikely to develop policies that will address some of these problems, there are communities. And in those communities, if we can get this going, we can show what happens to the well-being of people. And these become islands of models, islands of nurturance in every community, in multiple communities, that builds toward the kind of society that I think we all aspire to. And so on that note, I'm going to put this up. And if you go to that QR code, you'll get the Values to Action. You can join us. You can give money to us. You can criticize us. You can give us feedback. And I think if I stop talking, you will give us feedback. So I'll stop talking.
Thank you, Tony, very much. Very interesting presentation and generated lots of interesting conversation in the chat box. So I've been trying to follow that. We have a lot of questions, so let me get right into them. So one of the circumstances that we deal with every day here at NIH is that each of the institutes and centers, or most of them at least, that comprise NIH focus on one risk behavior or one health outcome. There are exceptions, but many of them are structured that way. And as a result, it's hard to bring them together to pool resources to address multiple risk factors and multiple outcomes. And Compass is an example of trying to do just that. And you found it and highlighted it. What made that possible was that it's a common fund project. So it's not being paid for out of any single institute or center, and it's not being paid for by taxing the institutes and centers to give up some of their own funds for that purpose. It's a separate pot of money that Congress provided. The question for you is, should Congress provide more resources of that kind so that NIH can do that sort of work? Because if we just go to the ICs and ask them to pool resources, that's really hard to accomplish. I wonder if you have thoughts on that.
Well, yes, clearly more investment is needed in that. But one thought that I have is that if you let's see, the first thing that would be helpful would be that Compass succeed on some of the things that it's currently doing. That would feed, support for putting more money into it, which is one of the reasons that I think the figuring out the methodology to do this, to make sure that it works. I'm not advocating commit-like interventions at this point. So making sure that works is, I think, very important. But the other thing is that I don't know how you do it, but we have got to get all of the institutes that are focused on specific problems to understand that their impact is going to be limited on those problems if they don't figure out how to address the omnifactors that have had less attention and that Office of Disease Prevention has called for. I don't know if that's helpful, but those are my thoughts.
Thank you. You've argued for developing intervention components thoroughly using interrupted time series or multiple baseline designs before those components get packaged into an intervention that's delivered in an expensive trial.
Right.
I'm sympathetic. I've also been watching Linda Collins and others who've been arguing for using the multi-phase optimization strategy to develop the package before evaluating it in an expensive trial. But that approach is rather different than running a series of multiple baselines or interrupted time series. Are there circumstances where you use one approach as opposed to the other?
I would have to study that. I've looked at what Linda has been doing with that. It seems reasonable. I think it requires more cases. And I mean, one of the beauties of the multiple baseline design is you're working with individual cases. But I don't think I have a good answer to your question.
Let's talk a little bit more about multiple baseline designs. One of the limitations that I've always recognized with multiple baseline designs is that they often involve only a few communities. Dr. Moyer and I were just reviewing a paper where there were 4 communities in the multiple baseline design. One of the examples that you had 4, so it's often just a handful.
Well, it had 8. I only showed 4, but it had
4,
8.
but it had 8.
Yep.
8 is a much more reasonable number to me. But often with a limited number of communities, there's not sufficient power for a statistical analysis, and we're left with an eyeball examination of effects. That may be perfectly sufficient if the effects are large, as they were in some of the examples that you showed. But we could put other slides up that would show results that you kind of stare at it and you're going, is there something there? Is there not something there? And it would be nice to have statistical methods to rely on to help us sort out those questions. It's not a problem for all multiple baselines, but that's the problem that I have sort of generally with that design. If the effects aren't large and clear, then it's hard to make sense of.
I would agree with you, but I think one of the things that behavioral analysts were insistent on was that if you have a single case, you'd better have a big effect, or so it actually called for big effects. If you've got 3 communities that you've done something in, I would want to see what the intervention was, but I mean, in a sense, when you say you want a large N, you're calling for replication, and I would call for replication as well. I'd want to see the example of the community intervention that you're talking about. We had in our NCI program, we did get a significant impact on youth smoking with an N of 16, 8 and 8. But it was in part because the components we used were working, and if you look at all of the studies we did on it, with each component we were studying what we could do to make that component work. So I
completely agree with you that we too often jump into an expensive trial before we're ready.
Yeah.
And before the components have been well tested and fine-tuned and so forth. So
yes,
completely agree there. And there are a number of people who've been making that argument. We've got questions about action circles. So could you speak to the similarities and differences between action circles and more traditional coalition building models that are used in community-based public health?
well, I don't think there's you would want to use those community organizing principles for sure, but the question is, how do you get started with that? And what we're doing in the RFP we're putting out is, and we have about 250 members of Values to Action who've joined, and most of them are behavior analysts, and they're all most of them are early career people, and they're desperate for their science to make a difference in things that go beyond what behavior analysis is typically worked on. And we think that we can get something started with those, but one of the things that will clearly be important is the community organizing principles. So I don't see any conflict from that. The question is, how do you get people started on working on these things? And can you, one of the things where I believe is that if you ask people to work on something for 2 months, a couple hours a week, you break it down, you got a product, and then that product is a brick that is a foundation for the next brick, and you keep doing that. And so people can see, they get some reinforcement for getting something done just in 2 months, and you increase the number of people who are doing that. That's my hope. And we're early in that process, and we have limited funds, but we think we can make a difference. I don't see any inconsistency with traditional community organizing. I think this is maybe one vehicle to help make that more efficient.
A follow-up that's closely related. How do you find the individuals to take part in the action circles to ensure diversity and that different voices in the community are represented? Do you feel this is hard to replicate in communities that you yourself are not a member of? Do you have to have a lead or a point person in a community who drives the research questions you ask?
It's clearly important. We were talking before the meeting started that we've been doing some work on diverse communities in Oregon, and despite what people believe, there are diverse communities in Oregon. And our feeling is that this has to be something that speaks to the needs of the community. One of the things we do with communities is we ask them to, we're working a small community in Oregon where there was a fair amount of conflict. We ask people if you would, if this were the most wonderful community could be in, what would you see, hear, feel, and do more of? And we ask people that, and we ask a couple hundred people, and we got a word cloud, and they're all positive things. And I've done this all over the world, and people all have the same positive aspirations, but they're their aspirations. And in that context, what could you do to improve things in your community? What's important to you in your community? So I think it's essential that the people living in that community be in control of this. And we're just beginning to work with the African refugee community in Oregon and beyond in the Northwest using these approaches. And one of my colleagues is, in fact, a member, he's an African refugee himself, and also a scientist at Oregon Research Institute. So yeah, it's essential. And I'm acutely aware of my whiteness and my age, and why would anybody want to trust me? I understand that. And it's really a matter of helping people who are members of those communities and building trust enough to be consultants to them. But they got to decide what they want to work on. And you and I know the history of prevention science and all the things that are possible, but we shouldn't expect that people who haven't been haven't had that experience to do it. So it's going to be difficult. I think the things that NIH is doing to increase diversity in the workforce is extremely important in that regard. And so
I'm going to let that be the last word, Dr. Biglan, and turn things back over to Dr. Moyer, because we have reached the top of the hour.
Thank you, Dr. Murray, and thank you to everyone who participated in today's webinar. On the Mind the Gap website, prevention.nih.gov/mindthegap, you will find several resources for this talk, including the slides and a list of references. We will also be posting a recording of today's webinar on our website in a few weeks. Thank you and have a great rest of your day.